Welcome back to the deep dive. All right, we've got a stack of revision notes here, something you specifically asked for, digging into a pretty critical medical emergency.
That's right. Today, we're really pulling apart subarachnoid hemorrhage, SAH. These notes are, well, they're packed with the high-yield stuff you absolutely need.
Yeah, whether you're revising for something like the MSRA or just need a really solid grip on this condition.
Exactly.
And that's our mission today, isn't it? To crack open these notes, pull out those essential nuggets, the bits that have to stick, and just make sense of them.
Turning dense points into something clear, something memorable.
Because with SAH, well, understanding it quickly, accurately, it's just everything, isn't it?
It really is. It's a true emergency. Recognizing it, knowing what to do next, it's paramount.
Okay, then let's unpack this. At its most basic level, what is a subarachnoid hemorrhage?
So it's bleeding. Bleeding into a very specific place around your brain, the subarachnoid space. If you imagine your brain's wrapped in protective layers,
Yeah.
you've got the dura, the arachnoid, and the pia mater right on the brain surface.
Right.
The subarachnoid space is that little gap, between the arachnoid layer and the pia layer.
Oh.
That's where the blood collects in SAH.
Got it. So blood pooling in that specific protective layer gap, and what's usually causing that bleed?
The vast majority of cases, the most common cause by far, is a ruptured intracranial aneurysm.
An aneurysm.
Yeah,
That's like a weak spot, a ballooning on a blood vessel wall in the brain.
exactly that. A weakened bit in an artery wall, it swells up, kind of like a blister, and then boom, it bursts catastrophically.
And the second most common cause you mentioned?
Less commonly, yeah, it can come from something called an arteriovenous malformation, an AVM.
Oh, right, and that's more like a tangle of abnormal blood vessels.
Precisely. It's like a short circuit, a messy tangle of arteries and veins without the usual capillary network in between. This makes them fragile, prone to rupture under pressure.
The notes also mention trauma, don't they, as another cause?
They do, yes. You can definitely get blood in that subarachnoid space from a significant head injury.
But for spontaneous SAH.
Right. When we talk about spontaneous SAH, the kind that happens sort of out of the blue, we're usually focusing on those non-traumatic causes like aneurysms and AVMs. But yeah, trauma is always in the differential depending on the story.
Okay, this is where it gets really interesting. Let's go a bit deeper into these causes, the etiology. Ruptured aneurysms, definitely number one.
They account for the lion's share. Absolutely. It's fundamentally a structural failure, a weakness in a brain artery.
And AVMs are the other main player.
Yes, those abnormal tangles.
Yeah.
They represent a different kind of vascular plumbing problem in the brain that can just, well, fail.
But the notes list a few other things too, less common causes.
Yeah, there are other possibilities. Things like vasculitis, that's inflammation of the blood vessels themselves. Certain types of drug abuse, particularly stimulants, are implicated. Even some brain tumors can rarely bleed into this space. Venous thrombosis, so a clot in a brain vein, can occasionally do it too. And like we said, trauma.
Right.
So what aneurysms dominate, you need to be aware of the sort of broader list for the full picture.
So who's more likely to get this? What are the key risk factors highlighted in these notes?
The notes are pretty clear here. A big one is family history. If you have close relatives with intracranial aneurysms or AVMs, your risk is higher.
And personal history.
That matters too, yeah. If you've had a previous SAH, even a small one, or if you're known to have an unruptured aneurysm already.
And the sort of usual suspects for vascular health, do they play a role?
Oh, absolutely. Front and center, hypertension, high blood pressure. It just puts extra stress on those vessel walls day in, day out.
Makes sense.
Smoking's another huge one. And interestingly, the notes actually give a specific figure for excessive alcohol intake.
Oh, yeah. What is it?
More than 37.5 units a week is quoted as increasing the risk.
Huh. That specific number really makes it stick, doesn't it? Any other risk details mentioned?
Well, they mentioned genetics generally play a minimal direct role, but obviously that family history link points to some kind of predisposition, doesn't it?
Yeah.
And aneurysm size is interesting. Logically, you'd think bigger is worse, and yes, larger ones, say over a centimeter, do have a higher rupture risk per year.
Yeah.
But the notes point out, most aneurysms that actually cause an SAH are smaller than that when they burst.
That is counterintuitive, so size isn't the only thing.
Not at all. Shape, location, growth rate, lots of factors involved.
And why is knowing all these risk factors so important for, someone revising this or seeing patients?
Because, and the notes really emphasize this, some of these are modifiable. You can treat hypertension, You can help people stop smoking.
Right.
Lowering systolic blood pressure, reducing smoking prevalence in the population, these things can actually decrease how often SAH happens. It directly links prevention back to the risks.
Okay, so what does this bleed actually do inside the head? Let's get into the pathophysiology, the process.
Right, so blood suddenly escapes into the subarachnoid space. Bang! This immediately causes a sharp rise in intracranial pressure, the ICP.
Like pressure building up in a closed box.
Exactly. You're pouring fluid into a fixed space, the skull, the pressure goes way up, and that pressure itself starts to compress and damage the brain tissue.
And the blood just sitting there causes more problems.
Oh, absolutely. The blood itself, and especially its breakdown products as it sits there, is incredibly irritating.
Irritating too.
To the delicate brain tissue, yes. But critically, it's highly irritating to the blood vessels on the surface of the brain, the ones sitting in that subarachnoid space.
And this irritation leads to that really key complication we need to remember.
Vasospasm. Yep. That's a crucial term for exams. The irritation makes those arteries constrict, clamp down, narrow significantly.
Which then cuts off blood supply further down.
Precisely. You get reduced blood flow to the parts of the brain supplied by those spasming vessels. This lack of oxygen and nutrients causes secondary brain injury.
Okay.
The notes call this delayed cerebral ischemia, or DCI. It's basically like having a stroke after the initial bleed, often days later, purely because of this vasospasm.
Wow. So the initial bleed is one hit, and then vasospasm causing DCI is potentially a second devastating hit?
Exactly. It's a major cause of long-term disability and death after the initial SAH has been survived.
This raises a really important question then. Someone comes in, sudden awful headache, you're thinking SAH. But what else could it be? What's on that differential diagnosis list from the notes?
Yeah, this is where you absolutely have to keep your thinking broad, even with that classic worst headache of life story. Other severe headache types are on the list.
Like
Migraine, maybe a really severe sudden onset one, cluster headache, and other headache syndromes the notes call primary headaches, the ones triggered by specific things like coughing, exertion, or sexual activity.
So that thunderclap onset, while classic for SAH, isn't unique to it.
No, definitely not.
Yeah.
You must rule out SAH urgently with that kind of story. But you can't stop thinking there. You got to consider other serious vascular stuff too.
Such as?
Cerebral venous sinus thrombosis, CVST. That's a clot in the veins draining the brain. It can also cause a severe sudden headache, sometimes seizures too.
What about infections? Meningitis?
It's on the list, yeah, though the notes point out that a true thunderclap onset is actually pretty rare in meningitis. You'd usually expect other signs like fever, maybe rash.
Okay.
Other kinds of stroke can sometimes present with headache, especially if they're hemorrhagic or involve certain brain areas, and of course trauma, if the history fits.
Anything else important on that list?
Yes, dissection of the carotid or vertebral arteries, tears in the neck arteries, can cause head and neck pain. A hypertensive emergency, just dangerously high blood pressure itself, can cause a brutal headache.
Right.
And a rarer thing called pituitary apoplexy, that's bleeding or infarction within the pituitary gland, can also give you sudden headache, often with visual problems or hormonal issues.
So it's quite a list to run through mentally when someone presents like that.
It is. Prioritize SAH, but don't get tunnel vision.
Let's look at the numbers then. The epidemiology. How common is this? Who gets it?
The incidence is roughly 6 cases per 100,000 people per year. It affects both men and women, but there's a slight female predominance mentioned.
And age-wise?
It's most common in adults, sort of midlife onwards. Peak incidence is often cited between 45 and 70 years old, with the average age around 50.
How does it compare to other types of stroke?
In Europe, the notes say it accounts for about 6% of all first strokes, which isn't huge, but given the severity, it's significant.
And there was a trend mentioned.
Yes, interestingly, a reported decline in incidence in Europe, quite a big one actually, over 40%, between 1980 and 2010.
That's massive, maybe linked back to that risk factor control we talked about.
One would hope so. Better hypertension management, less smoking, it seems plausible they'd contribute.
And the breakdown by cause again?
Yeah. Epidemiologically, the notes reinforce. About 85% are from ruptured aneurysms. Around 10% are these non-aneurysmal paramesencephalic bleeds, often around the midbrain, tend to have a better prognosis. And the remaining 5% are other rarer vascular abnormalities.
Any specific demographic groups with higher risk noted?
Beyond the modifiable risks, yeah. Women have a relative risk of about 1.6 compared to men. and Afro-Caribbean individuals are noted to have a significantly higher relative risk, around 2.1 to 1.
Geographic variations.
Yes, the notes mention higher incidence rates observed in places like Finland and Japan.
And just to be clear, this is all about spontaneous SAH, not the blood you see after a major car crash or fall.
Correct. We're primarily talking about the spontaneous type here, usually aneurysmal, distinct from traumatic subarachnoid blood.
Okay, let's put it all together. Clinically, if you're seeing a patient, what does this actually look like? What are the symptoms, the signs?
The absolute classic, the hallmark symptom you cannot miss, is the headache. Sudden onset, excruciatingly severe. And patients very, very often describe it using that exact phrase, the worst headache of my life.
That's a big red flag.
That's your number one alarm bell, absolutely.
What else often comes with it?
Neck stiffness is common. That's meningism from the blood irritating the meninges. Nausea and vomiting are very frequent. And often, some change in their level of consciousness. They might just feel a bit off, confused, drowsy, or right down to being unconscious, comatose. Seizures can happen too, either at the start or later.
Any specific triggers mentioned in the notes?
Yes, they specifically note it can often be triggered by physical exertion or sexual activity, anything that might suddenly raise blood pressure.
Okay. And on examination?
You might find that reduced conscious level, signs of meningism like photophobia and that neck stiffness. Sometimes a fever can develop. Signs of raised intracranial pressure like papilledema if you look in their eyes, though that takes time to develop.
And in the most severe cases, right at the outset?
Sadly, yes. A massive bleed can cause immediate seizures, deep coma, or even sudden death before they can get help. And the notes remind us again, women and older individuals tend to have a higher risk of a poor outcome.
Now, you mentioned something really crucial earlier, this idea of a warning sign before the big bleed.
Ah, yes, the sentinel bleed. This is absolutely vital for revision, high-yield stuff. It's thought to be a smaller leak, maybe from the aneurysm stretching, or a tiny rupture that seals itself temporarily.
What does that feel like?
It causes a sudden severe headache, but maybe not quite the worst ever. It might resolve after a few hours or a day, and it can happen days or even weeks before the major catastrophic SAH.
Like a warning shot.
Exactly, a warning shot across the bows.
And why is recognizing that so incredibly important?
Because the notes stress. If you suspect a sentinel bleed based on someone's story, this sudden, unusual, severe headache that maybe got better, they need urgent hospital admission and investigation now.
It's a chance to intervene before the big one.
Potentially, yes. It's a chance to find the aneurysm and treat it before it ruptures properly. You absolutely cannot afford to dismiss those warning headaches. They need investigation.
What specific things on examination might point you towards SAH or its complications beyond the headache and neck stiffness?
Well, consciousness level, as we said, can range from fully alert to deeply comatose. That neck stiffness is key. One really worrying sign the notes highlight is an isolated, dilated pupil that doesn't react to light.
What does that suggest?
That can indicate pressure on the third cranial nerve, the oculomotor nerve, often from the brain starting to shift or herniate due to the pressure. That's a neurosurgical emergency.
Okay. Anything else?
Looking in the back of the eye, ophthalmoscopy might show intraocular hemorrhages, Terson syndrome. You might find focal neurological signs too, like weakness down one side or specific cranial nerve palsies, making it look a bit like a typical stroke sometimes.
And blood pressure. You mentioned it's a risk factor, but what happens after the bleed?
Yeah, paradoxically, while high BP is a risk, after the bleed, the body often mounts a massive stress response. You can get a surge in blood pressure reactive hypertension as the body tries to maintain blood flow to the brain against the high ICP.
And that can cause problems itself.
Yes. This surge, along with the catecholamine release, can sometimes trigger cardiac arrhythmias or even stress cardiomyopathy, like Takotsubo. So the heart needs monitoring too.
Okay, so you suspect SAH based on this classic presentation. How do you confirm it? What investigations are key?
First step, the initial test, according to the notes, is a non-contrast, computed tomography, a CT scan of the head. You're looking for that white signal of blood in the subarachnoid spaces, the cisterns, the fissures.
But what if the CT is negative, yet you still have a really strong suspicion, that classic story?
This is where the timing becomes absolutely critical, and it's a really high-yield point in the notes. If that CT head is done within 6 hours of the symptom onset and it's completely negative, then the chance of missing an SAH is extremely low. The notes explicitly say a lumbar puncture, an LP or spinal tap, is not routinely needed in that scenario.
That 6-hour window is key then.
Absolutely crucial. Remember that time frame?
Yeah.
CT negative within 6 hours, probably not SAH.
Okay, but what if the CT is done later than 6 hours after the headache started and it's negative?
Ah, now then, an LP may be considered to definitively rule out SAH because the blood can start to dissipate or look less obvious on CT after time.
Right. And if you do the LP, what are you looking for in the cerebrospinal fluid, the CSF?
Where you're looking for blood, obviously red blood cells that shouldn't be there,
Yeah.
but the really specific sign, another high-yield term to know, is xanthochromia.
Which is the yellowing of the CSF.
Exactly. It's the yellow discoloration caused by the breakdown products of hemoglobin, like bilirubin, after red blood cells have been sitting in the CSF for a while.
And that takes time to develop.
It does. That's why if you are doing an LP after a negative CT done later than 6 hours, you ideally need to wait at least 12 hours after the headache started for xanthochromia to reliably develop and be detectable by spectrophotometry.
So CT first, checking that 6-hour rule, then LP maybe, but only after 12 hours from onset if the CT was late and negative.
Got it. Once SAH is confirmed, either by CT or LP, you need to find the source of the bleed. Right.
Precisely. Finding the cause, which is usually that aneurysm or sometimes an AVM, is essential for definitive treatment to prevent rebleeding.
How do you do that?
CT angiography, or CTA, is often the next step. It's non-invasive, uses contrast dye with the CT scanner to visualize the blood vessels and hopefully pinpoint the aneurysm or other source. It helps plan the treatment too.
And if the CTA is negative, but you're still convinced it was an aneurysm?
Then more detailed, often invasive imaging might be needed. Digital subtraction angiography, DSA, is kind of the gold standard. It involves inserting a catheter into the arteries, but carries small risks. Sometimes MRI angiography, MRA, is used too.
And routine tests alongside this. Yeah, standard bloods are important. Full blood count, urea and electrolytes, U and E's, to check kidney function and electrolytes, a coagulation screen to check for bleeding disorders, and an ECG is vital to look for those cardiac changes we mentioned, like ST elevation or arrhythmias.
Okay. And once SAH is confirmed, what's the absolutely non-negotiable next step the NERTs emphasize?
Urgent discussion with and transfer to a specialist neurosurgical center immediately.
Why the urgency?
Because the risk of the aneurysm rebleeding is highest in the first 24 hours, and rebleeds are often fatal. The patient needs to be in a place that can monitor them intensively and offer definitive treatment quickly. Time is brain.
Okay, so SAH is confirmed. The patient is on their way to or has arrived at the neurosurgical unit. What does the management plan involve there?
It's really a multi-pronged attack. You've got the immediate neurosurgical consultation. You've got intensive supportive care and monitoring, a huge focus on preventing complications, especially vasospasm, and then planning the definitive treatment to secure the source of the bleed.
Let's talk supportive care. What does that involve?
Close monitoring is key vital signs. Neurological observations like GCS, pupils, fluid balance, electrolytes, keeping the patient comfortable, managing pain, and that big one, preventing vasospasm.
Right. And how do they try and prevent that? There's a specific drug associated with this, isn't there? A high-yield one?
Yes, nimodipine. It's a calcium channel blocker. The notes state it should be administered orally to basically all patients with aneurysmal SAH, starting as soon as possible, to help reduce the incidence and severity of vasospasm and delayed cerebral ischemia.
Any specifics on using it?
Yeah, the notes mention titrating it or other supportive measures to keep the systolic blood pressure above 100 mmHg, ensuring adequate brain perfusion. So nimodipine for vasospasm prevention, definitely remember that link.
What if the patient presents really unwell? Reduced GCS, unstable.
That is straight into the ABCDE approach. Airway, breathing, circulation, disability, exposure. You might need to secure their airway with intubation if their GCS is low. Stabilize their circulation. Urgent neurosurgical input is critical.
What are the goals then?
Manage cerebral perfusion pressure, trying to keep the intracranial pressure, ICP, under control, often aiming for below 25 mmHg. Blood pressure management is also crucial here. You need to avoid it being too high, which could worsen bleeding or raise ICP, but also not too low, which would compromise brain perfusion. The notes suggest keeping systolic BP typically below 140 mmHg in the acute phase, but it's often individualized.
And watching out for problems along the way.
Constant vigilance. Monitoring closely for seizures, signs of infection, developing hydrocephalus, that's the fluid buildup, and critically, any signs of rebleeding. Also watching for Cushing's reflex, that triad of high BP, low heart rate, and irregular breathing, which signals critically high ICP.
What about symptom control? That headache sounds unbearable.
Absolutely. Good analgesia is vital, often needing strong opioids, antiemetics for the nausea and vomiting. Bed rest is usually recommended initially in a quiet, calm environment.
Okay, so that's the initial stabilization and supportive care. Then comes the definitive treatment, fixing the aneurysm or AVM.
Exactly. Once the patient is stable enough, and usually after angiography has clearly defined the problem, the neurosurgical team will decide on the best way to secure the ruptured aneurysm or treat the AVM.
What are the main options for aneurysms?
The two main techniques described are endovascular coiling and neurosurgical clipping.
Coiling is.
That's usually done via catheters inserted through the groin, navigated up into the brain's arteries. Tiny platinum coils are then carefully packed into the aneurysm sac, blocking blood flow into it and causing it to thrombose, effectively sealing it off from the inside.
Less invasive than open surgery.
Generally, yes.
Mhm.
And then there's neurosurgical clipping.
Which is?
That involves open brain surgery, a craniotomy. The surgeon directly visualizes the aneurysm and places a tiny metal clip across its neck, the point where it arises from the normal artery, completely excluding it from the circulation.
And the choice between them.
It depends on many factors: the aneurysm's size, shape, location, the patient's condition, local expertise. Both are effective.
And for AVMs.
AVMs are often treated with surgical removal, sometimes preceded or combined with endovascular embolization to block feeding vessels, or occasionally stereotactic radiosurgery. It's complex.
What about after the immediate crisis is over, the aneurysm is secured?
Recovery involves a long period of follow-up and rehabilitation. Often follows similar pathways to stroke rehab physiotherapy, occupational therapy, speech therapy if needed. Follow-up imaging is usually done to check the aneurysm repairs holding up.
What if they find other aneurysms during the workup, ones that didn't rupture?
The non-culprit or incidental aneurysms. The notes mention options here include treating them preventatively, again, usually with a coiling or clipping, or sometimes managing them conservatively with monitoring, depending on their characteristics and the patient's overall situation.
And long-term management after discharge. What do patients need?
Key things include really strict blood pressure control that's paramount. Decisions about long-term antiplatelet or anticoagulant therapy, which can be complex after SAH. Absolutely vital support for smoking cessation. And managing any ongoing problems like chronic headaches or seizures if they develop.
One last point from the notes on management. Testing relatives.
Right. They clarify that routine screening of all first-degree relatives isn't generally recommended or proven to prevent SAH overall. Screening might be considered on an individual basis, especially if there's a strong family history with 2 or more affected first-degree relatives, but it's not a blanket recommendation.
Okay. Let's talk outcomes. This sounds incredibly serious. What's the prognosis generally for someone who have an SAH?
It is serious, unfortunately. The mortality rate is significant. The notes state that overall mortality is over 25% at 6 months.
Wow.
And tragically, a substantial number, maybe 10–15%, die very quickly before even reaching hospital.
But if they do make it to hospital and get treatment for the aneurysm,
then the outlook improves. For those with a confirmed aneurysm that gets successfully treated, survival is much better, around 85% according to these notes. But surviving the initial bleed and getting to treatment is the first major hurdle.
what's a major cause of death after the initial event?
Rebleeding. If the aneurysm isn't secured quickly, it can rupture again, particularly in the first few days or weeks, and rebleeds carry a very high mortality rate.
And for those who survive, what's the long-term impact like?
It can be significant. The notes highlight that a considerable proportion, maybe 10–20%, of survivors become dependent on others for daily activities.
And cognitive issues.
Yes, cognitive impairment is common, affecting somewhere between 17% and nearly half of survivors, according to the range given. Problems with memory, concentration, executive function, mood changes like depression or anxiety, fatigue, speech issues, these are all common challenges for survivors.
What factors seem to predict how well someone does? What influences the outcome?
Several key things mentioned. The sheer volume of blood from the initial hemorrhage, bigger bleeds tend to do worse. Older patients generally have poorer outcomes. Their level of consciousness on presentation, a lower GCS score, is a bad sign. And whether the bleeding ruptured into the brain's fluid-filled cavities, the ventricular system.
Okay, let's list the specific problems that can arise during or after SAH, the complications.
We've touched on some, but let's be systematic. Vasospasm, that narrowing of blood vessels, is a huge one, and its consequence, delayed cerebral ischemia, DCI, that secondary brain injury or stroke from reduced blood flow.
Got it. Vasospasm leading to DCI. What else?
Rebleeding, as we discussed, very high mortality if it happens, 70–90%, especially early on before the aneurysm is secured.
Fluid issues in the brain.
Hydrocephalus, that's a buildup of CSF, either acutely due to blood-blocking drainage pathways or developing later. It often needs treatment, like an external ventricular drain temporarily, or sometimes a permanent shunt. Seizures are another complication, both early and potentially long-term epilepsy.
And the heart.
Cardiac complications, yes. Triggered by that massive stress response and catecholamiне surge, things like stunned myocardium, neurogenic stunned myocardium, ECG abnormalities that can mimic a heart attack, arrhythmias, and sometimes significant drops in blood pressure, hypotension.
Electrolyte problems, too.
Yes, the notes mention electrolyte disturbances are common, particularly problems with sodium levels. Conditions like cerebral salt wasting syndrome or syndrome of inappropriate ADH secretion, SIADH, can occur, requiring careful fluid and electrolyte management.
Any other immediate complications right after the bleed?
Well, those rapid changes in intracranial pressure we talked about, acute hydrocephalus. Sometimes the bleeding isn't just in the subarachnoid space, but extends into the brain tissue itself, causing an intracerebral hematoma, or under the dura, a subdural hematoma, and general brain swelling, cerebral edema.
And long-term, after they go home.
The risk of developing epilepsy persists. The notes say 5% or more might develop it after discharge. And those ongoing cognitive impairments we mentioned, memory, mood, concentration, fatigue, are major long-term complications impacting quality of life.
And just to reiterate, those factors influencing prognosis, bleed volume, age, initial consciousness level, ventricular rupture, they also influence the risk of these complications occurring.
Yes, absolutely. They're markers of the severity of the initial insult and predict both overall outcome and the likelihood of running into these specific problems.
Wow. Okay. We have really pulled these revision notes apart on subarachnoid hemorrhage. From the basic definition, like the nasty causes, who's more at risk, what it actually does inside the brain.
Yeah, through to what else it might look like, the epidemiology, how it presents clinically, that terrible headache, how you investigate it. Crucially, remembering those timings for CT and LP.
The whole management pathway from A&E to neurosurgery, nimodipine coiling versus clipping, the long-term follow-up.
And finally, the often sobering prognosis and that long list of potential complications, from vasospasm right through to long-term cognitive issues.
Taking a complex topic like this and really structuring it, pulling out those key terms, those clinical decision points directly from the source material, well, it just makes such a difference for revision, doesn't it?
It absolutely does. It helps frame it, helps make it stick when you're under pressure, turns those dense notes into something you can actually use.
Definitely. So, as a final thought for you to maybe mull over, consider this practical challenge, recognizing that sentinel bleed. Given how potentially deadly missing it could be, how would you integrate what we've discussed from these notes into your own thinking, your own practice, to make sure you don't accidentally dismiss that patient whose worst headache wasn't quite the textbook thunderclap but still sounds suspicious?
That's a really critical question for anyone working in acute medicine or primary care. Maintaining that high index of suspicion is key.
Indeed. And if you are hitting the books hard, maybe for the MSRA, or just want more ways to drill down on these high-yield concepts,
then we definitely encourage you to check out passthemsra.com. Loads of great resources there.
and also worth looking at framishray.com as well for more practice.
Absolutely. Well, thanks for joining us on this deep dive into SAH. We really hope breaking it down like this helps you get a solid handle on this vital topic.